So it's a pleasure to talk about a subject that's interested me for a long time, and that is better risk assessment for breast cancer. This originally started when we ran our first prevention trial, identifying high risk who we could give tamoxifen and later aromatase inhibitor to. And one of the big challenges in that field was to better identify women who are truly at increased risk and to identify as many as possible. So that's kind of where this all started, and it's continued to sort of grow through the years. So I should disclose that the model is now licensed by Cancer Research UK, and I get a very small royalty from that. Everybody knows a little bit about density. These are 4 mammograms from fatty replace to homogeneously dense with intermediate patterns. And the mammograms, of course, are conventionally used just to look for cancers when they're small. But one of the big uses, which we're just beginning to realize, is it probably tells us more about who's going to get breast cancer in the future than anything else we know in terms of a population basis. Certainly if you're a BRCA1 carrier, your risk is high, but that's so rare, it's not that helpful on the population. But there's this big spread of risk associated with density. A woman with a fatty replaced breast down here compared to one that's got a very dense breast, the dense breast woman is about 4 times as likely to get breast cancer as this one. And these groups are all reasonably large, probably 10% out here, 30 to 40% here, 40 to 50% here, another 20% down here. Depends a bit on age, but there is a real spectrum. It's not just picking out 1 or 2 people, but in the general population, it's picking out a real spectrum of disease. So one of the things that was a real challenge is that we have the classical model, the IBIS model we developed for risk based on family history, age at first childbirth, age at menarche, menopause, and a whole range of questionnaire data. And the challenge was, how do we actually integrate density into that? Well, the most important thing to be aware of is that density really very much depends on age. Your density goes down with age, particularly after the menopause, and it also depends on weight or body mass index. That heavier women actually have larger breasts, but they're more often more fatty replaced. So the percent density is generally lower in those women because they have more fat in their breasts. So it's important to make those adjustments. And what we do is we basically look at the breast density after adjusting for what your age is and what your body mass index is, and basically develop a residual or a kind of score of where you lie for women of the same age and the same body mass index, which is included in the model already. And so basically we do that. I wanted to show you just a little bit of data of how useful that's been. One of our major collaborators in big groups that we've actually worked with is called the PROCAST study, which is done in Manchester. It's over 50,000 women coming for routine screening. They've had the full Tyrer-Cuzick risk model assessment, plus we have densities on all of them, and about 10,000 of them also we had a saliva sample to look for what's called polygenic risk score, the SNP score, single nucleotide polymorphisms, which is turning out to be the 3rd important factor. So there was almost 700 cancers in this population up to the next screen, which in the UK is 3 years later. So we've looked at that, and this gives you a sense of how important density is. The Tyrer-Cuzick model is all of the classical factors, and this number here is a little bit hard to understand. It's the risk change from going to the 25th percentile to the 75th percentile of the risk profile. So it's a kind of abstract number, but you can compare things based on that. And classic factors allow you to be able to have about a 36% increased risk from the 25th to the 75th percentile. If you look at this density by itself, it's actually bigger. It's a 48% effect. So there are actually more information in density than there is in all of the questionnaires in terms of who's going to get breast cancer in the next 3 years for this study. And what's particularly interesting is, in fact, they're almost completely independent. The information in the density has nothing to do with family history or all the things that you might get from questions. So when you adjust the density for information that's in the classic model, it doesn't change the benefit at all. They're essentially completely independent risk factors, and knowing them both essentially doubles your knowledge about risk compared to just knowing one of them. So we've also looked specifically at 3 big studies in which we've got the Volpara volumetric density, which is available as well. And in the ProCast study, the effect is just the same as a visual assessment, just as strong, not better, but of course the great strength of the volumetric approach, it is an objective measure that you get the same answer. You don't rely on the subjective interpretation of the radiologist, which changes if you give them the same mammogram 6 months later. They'll give you a different number. If you get different radiologists, they'll give you different numbers for exactly the same film. And the great thing about this is an objective measure that you can actually comes off the machine directly, no physician intervention, that's the number. We've also looked at it in a large Swedish cohort of about 70,000 people. This is Per Hall's KARMA study, and the effects are even better there. The risk ratio was 82% change in risk. We don't know why it's that much better in Sweden, but in fact it is clearly a very important factor there. And then lastly, in the US, we worked with Jennifer Harvey in the University of Virginia data set. It was a large case control study of women coming to their center. And the risk there was virtually the same as in the ProCast study. So a whole range of different populations, we've demonstrated that this works very, very well and is a really important addition to risk assessments. Just to sort of show you a few other things, in the Virginia study, we're actually able to also compare it to BI-RADS. They had both of them. The differences are not really significant. These are well within the confidence intervals. So basically, it didn't perform better than BI-RADS in terms of prediction with an expert reading the BI-RADS, but it was just as good and completely reproducible. So you didn't have to worry about whether if it got read another time, it would give you a different answer. So we're quite impressed with the fact that this is really a solid test that you can use routinely. You don't have to train your radiologist to read density well. You just get the number and we know it works. So the last data we've looked at is actually data from a large cohort recently published in JAMA Oncology. Brent was the first author, in which this is 120,000 women with about 10 years of follow-up altogether in the full model. And this breaks out the risk according to your 10-year risk. Typically, it's about 2 to 3%, sometimes up to about 4% in the general population. Depends a little bit on age. And in the UK, if your risk is above 8%, which is about a tripling of that 3% here, you're entitled to get preventive therapy. In fact, the government recommends it should be offered tamoxifen or aromatase inhibitor. If you're in the next group, between 5 and 8%, the recommendation is your doctor should talk to you about that, and you should also consider getting extra screening. At the moment, we're trying to make that more routine in the UK. That will begin to happen. And then at the other end, very important as well, women at low risk probably need less screening. If you're not going to get breast cancer, and we can say that reliably, then if we could say that perfectly reliably, then there would be no need to screen at all. But if your risk is sufficiently low, a less than 1% chance of getting breast cancer in the next 10 years, you definitely need less than annual screening. And I think we need to begin to separate the population in so-called risk-adapted screening, in which some get more, some get less. And that's where we're trying to go. Now, this slide also looks at the additional predictive value when you add density. The yellow is just looking at the classical factors. And if you look at the greater than 8% 10-year risk, you can see it almost doubles by being able to add density. So it goes from in this study, from about 3% to just over 5%. If you add the SNP score, which we'll look at it a little bit more later, you can actually get another increment. But it is clear that if you're really going to try to do risk-adapted screening, making use of the information in the mammogram is really key in terms of getting this discrimination you want. You identify a lot more at low risk. It's up to almost 8% now, who probably could be screened every 3 years rather than annually, as is done in the US now. And you can double the number that are at high enough risk that you really should be doing more than just mammography. Probably MRI screening in many cases, and also considering preventive therapy in those that are prepared to consider that. So that's just focusing on that. So just looking at those numbers again, just to reinforce that in the Washington cohort, the amount of information increased enormously. I won't go through the technical aspects of likelihood ratio chi-square, went from 500 to 750. But in terms of accurately identifying the number of women at more than an 8% 10-year risk in this other cohort, it was 2% without density, and it jumped to almost 4%, 3.8%. So we've doubled the number of women who are at high enough risk that they need to consider a lot more than just routine screening. So we're very excited about that. And just to finish, a little bit about something that's, I think, less known in many people. I get most of the questions about that. They're called these single nucleotide polymorphism risk scores. And basically, everybody knows about the very rare high-risk genes that cause breast cancer, BRCA1, BRCA2. But they're rare. They're less than 1 in 500 women carry them in the general population. If you have them, it's important, and it's also important for your family. But in terms of what's useful in the population, they're too rare to be really that useful. And what's actually developed now is that there are a lot of genes that individually have small variations that increase your risk by 5 to 10% or decrease your risk by 5 to 10% from the general population. Now, individually, a 5% change in your risk is not even worth worrying about. But we now have 147 of these, and if you start looking at panels of them, some women have a lot more high-risk genes than low-risk genes, and their risk is increased. Some are the other way around. They have more low-risk genes, and so even if they've got a weak family history, you might say your risk is not that high, whereas other ones with weak family histories, if they've got a high-risk score plus maybe a dense breast, that pushes them up into that high-risk group, not just family history by itself, but breast density and these low-risk genes in big panels can tell you quite a lot. So as I think I've said all of that, you need to pull them together individually. They're not that great, but when you have as many as that, we used 88 in some of our papers, but it's now up to 147. And a recent paper, actually, this is an older paper, in JAMA Oncology just this year, has actually looked at that in the Washington cohort and showed how important all of these factors are. So again, looking at Manchester, it's the only place we have density well measured plus the SNP scores. We did this on a case control study, about just under 9,000 controls that had they gave a saliva sample, all done on saliva. Quite simple to do. We only looked at 18 SNPs here, and we had almost 500 cases. And density was just done in the old-fashioned way by a visual assessment here. So this gives you a distribution of risk. If you just looked at the classical questionnaire data, it shows that we use less than 2% in this paper. We should use 1% to be consistent. About 15% of the women are at low risk, and only about 2% were found at that very high risk. If you add density, as I said, you virtually double your ability to find the high-risk group, and you substantially increase your risk to the low-risk group. So essentially a doubling of the people that you need to do something special about. If you add this SNP score, it almost increases the same amount again. So it goes from like 2%, 4%, 6%. So altogether, these are independent factors, all important, all can be done simply at the time of screening by getting a good density measure, asking a few questions, and taking a saliva sample, which isn't really a lot of work. Questionnaire takes 5 minutes for most women. once you get good at actually doing it. Some people complain they have trouble dealing with it, but it is not a big issue. The density comes automatically if you use Volpara, and we think this is really important to think about. Not screening shouldn't be one size fits all. You wouldn't do that in other aspects of medicine. You wouldn't treat everybody the same. You treat them according to what their particular personal need is. And we're beginning to be able to do that in breast cancer screening as well. And I think it's the way forward. So thank you for your attention.